So our next session is titled 2017 ANCA Workshop Update. And I'm pleased to introduce Dr. Dua, and just a little bit about Dr. Dua. She joined the University of Chicago in December of 2013 as an assistant professor of medicine in the Department of Rheumatology and the director of the fellowship program. She sees patients at the university's vasculitis clinic on the main campus in Hyde Park, as well as in downtown Chicago. She has a special interest in teaching patients, medical students, and residents about achieving optimal management of autoimmune rheumatic conditions. Please join me in welcoming Dr. Dua.
I'm Anisha. I'm from the University of Chicago. Thank you for introducing me, and thank you all for being here today. I'm going to give you an update on the International ANCA-Associated Vasculitis Conference that was held in March of this year in Tokyo. And the theme of the conference was diversity and integration for tomorrow. So there were multiple countries that were represented, multiple subspecialties, and we were all just basically trying to share the research that's been going on so we can really come to a better understanding of the vasculitides. This is just sort of an idea of where we've come. So a lot of this information some of you have heard in the small groups, but I'll sort of give you an idea. So, in the 50s and 60s, we were really heavily relying on steroids and Cytoxan. There weren't really any other options. And you can see in the early 2000s and through now, there's just really been a surge of research in the area. That includes just ways of trying to minimize toxicity from those drugs with different therapies that could be used for induction and then other therapies that could be used for maintenance. And you can see, I couldn't fit it all on here, but as you get closer to the current, there's a lot more lines and boxes, which is very promising and exciting. I'll talk about some of them. So there were 451 abstracts presented at the conference from 29 countries. So I'm going to read all of them. Just kidding, I talk fast, but not that fast. But it's exciting that there were that many. So that it's just showing that there's a lot of research going on. But I'll kind of go through some of the main themes that were discussed. The first is the classification of the ANCA vasculitides, pulmonary limited microscopic polyangiitis. There was discussion about Takayasus and giant cell arteritis, whether these are two separate diseases or more of the same spectrum. Each EPA, and then just some quick therapeutic updates. So for classification, there has been some discussion about this at the conference, but we rely very heavily on autoantibodies, so PR3 and MPO, to help guide us in classifying patients, enrolling people in clinical trials, and to help us predict the risk of relapse and which organs may be involved. Now, this is not that difficult. It's easy to do when you have a classic presentation or organ involvement, a matching antibody, and especially if you have a biopsy with a tissue diagnosis. So someone with upper airway disease, a positive PR3 and a biopsy showing granulomas, great, we have a diagnosis GPA. It becomes much more difficult when you have overlapping features, things that don't quite fit, maybe the opposite antibody, which we know is something happened, or maybe not even having the antibody. It's not always safe to get tissues, so sometimes we just have to sort of put different pieces together to know where to classify people. And genetic studies align more with autoantibody specificity, so the PR3 or the MPO, rather than the clinical syndrome. Having specific genes can increase the risk of relapse. Now, since we're kids, we've always sort of had these boxes. We try to fit the shape into the hole and just make something fit. And even when it doesn't, you just sort of shove it in there. And it can be frustrating when it doesn't fit, but that's not really the way that we want to approach classifying these diseases. By getting more information, we can really understand better what our patients are facing and what might work in different situations. So combining the serotype, the MPO, the PR3, and the clinical or pathologic phenotype will give us the most informative diagnosis, and it will allow us to better categorize the patients, all of you, not just based on a blood test or one biopsy result, but using all this information to really sort of drive forward the process and try to understand the nature of these diseases. In terms of epidemiology, there's been a lot more interest in developing longitudinal databases, which is also very exciting. This is the UK IVAS. There's also the DC VAS that some of you have heard about. These are longitudinal registries. This one has over 3,000 cases of all different types of vasculitis, and it will hope to be a big source for making comparisons between different countries and possibly for biomarker studies in the future. We know at this point our main biomarker is ANCA, and as that's come into regular use in the late 90s, 2000s, we've been able to diagnose people earlier, have more clinical trials involving these patients and everything. And it's led to improved survival and patient outcomes. But as people are living longer and we have all these new treatments, we really have to be vigilant about the chronic damage and comorbidities that sort of come along with that. And hopefully registries such as this one will capture this important information so we can better study vasculitis, including the damage from the disease and then also the comorbidities and therapies that we're using to try to control it. So going on to pulmonary limited MPA, we know that there are different types of lung involvement in microscopic polyangiitis. That includes alveolar hemorrhage, interstitial disease, or bronchial disease. Lungs are involved in about half of patients with MPA, and we're finding an increasing number of people who have this interstitial pneumonia or interstitial disease in their lungs, and then they're getting blood tests done, and then they find that they have a positive antibody. Now, what does this mean? Does that equal they have vasculitis? Does that mean we need to start immunosuppressing them? Are they going to develop systemic vasculitis, or where do we really classify these patients? And that's an important question, because a subset of those patients will go on to develop systemic vasculitis after about 4 to 5 years, and it's more likely when they have a high titer of MPO. But some of them, it will remain just sort of that CT scan change in their lungs with this positive antibody. So understanding that patients, working with our pulmonary colleagues, that patients initially presenting with lung disease or a diagnosis of interstitial pneumonia may go on to develop other systemic signs of vasculitis, helps us to watch them closer so we can diagnose them or intervene sooner. But when you have this person, are there any clues, are there any lab tests, any imaging studies, anything that will give you an idea that this person is going to develop a systemic vasculitis? We need to be pretty aggressive, or we can just sort of watch them and they probably won't. We do rely on imaging, but that's not always the answer. So the top picture is a picture of a CT scan of the lungs showing what's called ground glass opacities. Looks maybe a little bit like ground glass, it's kind of fuzzy. That's a picture that happens when people have alveolar hemorrhage. And then on the bottom, you can see what we refer to sort of as cysts and honeycomb changes. So those are a little bit easier to distinguish between each other, but it can be difficult to figure out whether there's active vasculitis or fibrotic lung disease in these MPO positive patients. And we want to know that because with inflammation, we want to shut down the inflammation, right? Whether it's with steroids or a different type of medicine. But if it's damage or scar, you can't really necessarily shut it down. We can try maybe thinking about antifibrotic agents to loosen up the scar. But you really do want to know the difference of what you're treating because it helps you figure out what to use. Interstitial pneumonia is the primary pulmonary manifestation in MPA patients, and like I said, it happens in more than half of people. And in the ANCA positive patients that we're finding, there's more of this honeycombing and cyst pattern. And it, ideally we always like to get tissue so we can say we've got our hand on it, we know what's going on. It can be sometimes dangerous to get tissues in these patients, and in the patients that have, there hasn't been really clear clues on the pathology to tell us these people are going to develop systemic vasculitis and these people are not. Why does this matter? With limited GPA, where there's more upper airway involvement, we approach it a little bit differently. We might use methotrexate to induce people. We might keep them on maintenance a little bit shorter, as opposed to systemic GPA. And with these increasing reports of just pulmonary involvement, that's sort of diffuse in the lung and not just a local area of injury, we need to see if we should develop some different types of treatment guidelines for patients presenting really exclusively with lung disease, and try to better identify who's going to go on, like I said, to develop other disease manifestations and who is going to have disease that stays in the lung. So this is really what I said. There's multiple studies that are being carried out in different countries on this limited, possibly new category of limited MPA, and we want to look for predictive factors to see if they respond differently to therapeutic regimens that target fibrosis or not. So then moving next to Takayasus and GCA. I know this is outside of the ANCA vasculitis, but there was a good section on this in terms of the research that's been going on, so I'll talk a little bit about that. The main problem here is that there's a major delay in diagnosis, and we all know if we find something sooner, we can treat it, we get better outcomes, right? So the point is to try to identify these people complaining with various different complaints and clinical symptoms and really be able to categorize them and start treatment. In Takayasus, the average delay is 258 days. That's a long time to have an inflammatory disease that's causing major damage in your blood vessels and not have a diagnosis. It's shorter in giant cell arteritis, which is likely because the giant cell arteritis patients tend to have more cranial symptoms, so they'll complain of headaches and have a little bit more classic features that we can recognize. But there's a lot of overlapping features, especially as we learn more about the large vessel involvement in giant cell arteritis and large vessel only disease even. There's a lot of overlap, and as a community, we're trying to relook at the classification criteria for both of these diseases. And I just want to make a quick distinction between classification criteria and diagnostic criteria. all of the criteria we come up with are really, a lot of them are classification criteria, and they're really intended to try to figure out who will fit into different clinical trials so we can try to find out therapeutics for the disease. But we often use them as diagnostic criteria, and that can lead to a little bit of confusion and difficulty when we're trying to figure out the right treatments for the disease. So this is some of the confusion here. You can see there's a good amount of overlap. Both sets of diseases have weight loss, fatigue, claudication where there's just pain in your extremities because of lack of blood flow, angiogram or imaging studies showing areas of stenosis or tightening. In giant cell arteritis, one of the classification criteria says an age greater than 50. Takayasus says age less than 40. So what if you're 45? Does that mean that you can't have either of these diseases? Obviously not. So, this is an important thing to think about. And does that mean that somebody who has classic Takayasu symptoms at the age of 60 doesn't have that disease? No. So we need to find ways to sort of recognize these patients and get a better understanding. In giant cell arteritis, like I said, one of the reasons we can recognize it a little bit earlier is because of some of the classic symptoms like headaches, polymyalgia, so soreness in the shoulders and hips, high inflammatory markers. It tends to be more common in Caucasians, and there's a lean towards females, so about 2 to 1, and it's associated with MHC2. In Takayasus, there is more lower extremity claudication, some more damage and bruise when we listen, showing like a problem, like decreased blood flow on exam. There's more renal involvement. Both of these diseases affect branches of the aorta and vascular beds, so there's a higher number of vascular beds affected. In Takayasus, tends to be more in patients of Asian or Turkish descent, and there's a much more heavy female lean, so 9 to 1 ratio, and that's associated with MHC2. But like I said, there is a good amount of overlap, and it can be confusing. So how rigid should we be with our criteria? There's currently a Japanese registry of late onset Takayasu, so patients who have classic Takayasu symptoms who are older than 40, which is a very understudied group. But by appreciating some of the differences in susceptibility, some of the imaging findings, and an increasing awareness of late onset Takayasus as well as large vessel giant cell arteritis, we hope to be able to decrease the time of diagnosis for patients who have these diseases and be better equipped to sort of differentiate them so we can study them better and closer in clinical trials. So just moving quickly into the treatment experience with these, do we really need to classify them, or are we going to use the same drugs for everyone anyway? Which is a reasonable question. So we all know steroids work well, and we tend to use high doses and prolonged courses in both of these diseases. And every time somebody relapses or flares, we end up using it again and starting almost over, which can be very frustrating for everybody. There have been studies looking at methotrexate in both of the diseases, and a meta-analysis looking at it, and there's a modest benefit. If I'm using methotrexate, I usually use a high dose pretty quickly to see if it'll help get control of the disease. With TNF inhibitors, so adalimumab, etanercept, Remicade, they look promising in case reports and some retrospective trials, but they didn't show any benefit in the randomized control trial, which again highlights the importance of doing these randomized control trials instead of just using anecdotal experience, because really it looked like it was going to work and it did not. Abatacept or Orencia works on T cells, and Dr. Langford gave a talk on this, and it was shown to be better than placebo at 12 months in preventing relapses of GCA, but that benefit was not seen in terms of relapse-free survival in Takayasus. So again, there are some differences in terms of response to treatment. So what's happened now, the new kid on the block, or the real exciting part here, is the role of tocilizumab in IL-6. So IL-6 has a lot of different properties. It's a protein, it's a cytokine protein, and it basically can result in fever, inflammation. You can see this little diagram on, I guess that would be your right. It stimulates B cells to make antibodies. It stimulates neutrophils, which we know are important in the ANCA vasculitis. It tells your liver to pump out more inflammatory C-reactive protein. And it actually sort of inhibits one of the cells that's meant to try to calm down our immune system. So it has a lot of different roles. And it was found to be elevated in patients with these large vessel vasculitis in their blood and also in the tissue of their blood vessels. So again, we're trying to move towards targeted therapy, and as we learn more about what's going on in these diseases and the pathophysiology, we can try to target those specific things and hopefully get those side effects. So the idea of tocilizumab is to block this cytokine that causes all these problems. And by blocking this receptor, the IL-6 that's floating around can't bind, and you don't get all these downstream effects. So the GIACTA trial was the big trial looking at this. There were 250 patients from 14 countries, and it included patients with both new or relapsing giant cell arteritis. And the patients that were treated with tocilizumab did much better than the steroid-only arm. They had more sustained remission, they did not have an increase in adverse events, and they reported better quality of life measures. This is really a big deal. I mean, there's been no new therapies for glandular arteritis in more than 50 years, and tocilizumab was just approved by the FDA. So the landscape really is changing, and we hope to be able to improve the lives of patients based on these trials, with the hope of less or possibly no steroids in the future, which is really the holy grail of all of this, trying to get control without using as much steroid. So we figured it out. Are we done? We kind of found this drug, and we're good. No, it's really a breakthrough and a landmark study, and the approval is very important, but there's so many questions. Every time we find one thing, we find 100 more questions, which can be frustrating but also exciting because it gives us new things to look for. But questions like, which patients are most likely to benefit? Is it just right off the bat when you have a new diagnosis we start this, or when you're having a flare? Or are there any clues? Is it the cranial patients who are going to do better, or large vessel involvement that's going to do better? How long should we use it for? Do we just keep you on it indefinitely? I mean, these are immunosuppressive drugs. Can we safely pull that off and hope that things don't relapse? Can we get away with using a lower dose? At what point in a flare do we start it? Can we get patients off steroids even faster than they did in these trials? And the cost. I think the cost is huge, and so the cost benefit, should we use this across the board, or should we just be sort of picking specific instances where it's going to be most effective? Those are all questions that remain, and hopefully with the open label phase we'll answer some of those. Moving on to EGPA. So this is the rarest of the ANCA vasculitides, and it's associated with late onset asthma, pulmonary infiltrates, neuropathy, and peripheral blood eosinophilia, so increased eosinophils, or a specific type of white blood cell in the blood. About a third of EGPA patients have a positive p-ANCA antibody, and those with the positive antibody tend to have classic vasculitic manifestations like the neuropathy or skin findings, whereas the ANCA negative patients more frequently have cardiac manifestations, including cardiomyopathy or myocarditis. So again, this disease course and response to therapy is different in EGPA compared to some of the other vasculitides, and they've been largely excluded from some of the big trials looking at MPA and GPA. So we try to extrapolate our information from the other trials and say, let's use our usual culprits, Cytoxan, azathioprine, methotrexate, and see if we can get control of the disease. But a lot of the symptoms, especially the chronic asthma or the rhinosinusitis, usually require really, again, high-dose, long-term steroids with a lot of toxicities that we all know about. And steroids are really like an umbrella. They sort of shut down your immune system from a large scale, and we hope that we're controlling the disease sort of in there. What we're trying to move towards is targeted therapy, figuring more out about what's driving the disease and then targeting specific areas in there so we don't end up with all of these side effects. So environmental exposures in both asthma and EGPA trigger the immune system through these cells in the airway that secrete these inflammatory proteins. And this response also occurs in the nasal passages, in the ear and nose and throat. So these triggers sort of do these T cells secrete these proteins, IL-4, IL-13, and IL-5. And this sort of feeds back again and causes more activation of the same cells. So you've got this circle of just constant inflammation, and we want to try to shut that down. So as we're learning more, we found that IL-5 is a cytokine, like I said, that regulates the growth and activation and survival of eosinophils, which is a critical part of the EGPA. And they are found in increased levels in patients with EGPA and associated with disease activity. So mepolizumab is a monoclonal antibody that basically targets this IL-5 and shuts it down so that way you don't get this activation of eosinophils. And it's been shown to be effective in asthma. And 2 pilot studies in EGPA showed promising results. There was a steroid-sparing effect. Patients were able to remain in remission maintenance, but then once they stopped the drug, they started to flare. So that'll again ask the question, how long do we need to keep this on for? And there's a favorable safety profile. So the MIRA trial is the first ever double-blinded placebo-controlled trial in EGPA patients to look at the efficacy and safety of mepolizumab in relapsing and refractory EGPA. The results of this trial should be available in late 2017. So this is exciting. It needs a possible medication outside of steroids that's tailored to and targets the mechanisms that really drive the disease. And then just briefly, the way I end about a couple therapeutic updates. The Maynardson trial was one of the trials that demonstrated that rituximab was superior to azathioprine at maintaining remission at 28 months. We now have some follow-up data at 60 months. And again, it really showed that maintenance therapy with rituximab was superior to azathioprine and associated with better survival. Does that mean that I switch anyone that's doing well on azathioprine to rituximab for maintenance? No. I mean, people do well on their drug. It doesn't mean that you have to switch over or that one is necessarily better. Also with this trial, rituximab was used at every 6-month mark, regardless of your activity or regardless of your ANCA level or anything like that. Azathioprine started at 2 milligrams per kilogram and kind of tapered down over this time. So we're finding out more about what the best ways to keep people in remission are. And there may be a role for ANCA monitoring, and some of those questions will be answered as we do the trials, looking at repeat fixed dosing versus dosing when people's B cells repopulate or you start having more symptoms. So hopefully we'll come up with more answers to that soon. And the last update was really looking at mycophenolate or Cellcept versus Cytoxan for remission, induction, and non-life-threatening relapse. So we know Cytoxan is used to get people into remission with ANCA vasculitis, and Cellcept or mycophenolate can be used in non-life-threatening disease. But what about when you've gone into remission, but now you're having relapses, so your first or second relapse? Do we have to keep going back to these heavy guns, or can we get away with something a little bit better tolerated or milder? So in this trial, the patients with increasing disease severity, less Cellcept-treated patients attained remission, whereas the induction of remission with Cytoxan therapy was unaffected by disease severity. The disease-free survival was not significantly different at 4 years of follow-up. And what does that really mean? It means that Cellcept or mycophenolate works well, it's less toxic, and it's a viable alternative to Cytoxan in relapses of ANCA vasculitis disease if your organs are not affected in a life-threatening way. So it is an option. So where are we going? Like I said, there's been so many new things that are coming up, and we've learned a lot. I've learned a lot at this conference. But there's a lot of exciting new trials that have been going on, randomized trials, and hopefully a lot of trials where we'll get some of the results as we move forward. It's a marathon, not a sprint. You guys know this better than anyone else. So as we move forward, hopefully with more collaboration between different countries and different subspecialists and all of you, we can really sort of just keep pushing forward in terms of coming up with better ways to diagnose and understand and treat these diseases.